Start the video. Good morning, everyone. I'm here in Tucson, Arizona, in the beautiful, what is this, the Medical Research
Building.
Medical Research Building. If you come here, park and visitor parking garage A, not where I parked. That was the wrong place. But I'm here with Dr. Scott Sherman, and we're in this beautiful, light-filled atrium. His office is behind us, and where's your lab?
It's on the other side of the wall back
on
here.
The other side of the wall. Yeah. So we're in a good spot. Lots of good Parkinson's things happening here. And just so all of you know, you've all been muted. If you have questions, you can save them for the Q&A portion, or as they come to you, there's a chat function at the bottom of the screen. You can type them in there, and then we can relay them to Dr. Sherman. And I did a microphone check before, but by a, thumbs up, show of hands, is the level okay? Can everyone hear? It's nice and clear? Okay, I see lots of thumbs up. Oh, I see someone raise their hand too. Looks good. And here in Tucson, today's daily high is still like 100 degrees. I see some of you look to be wearing long sleeves, so you must be in other parts of the country. And I think that one of my colleagues is going to do the formal introduction. Is that right? Is that you, Maureen, who's going to kick it off for us?
That would be me. That would be me.
Okay.
Thanks, Andrea. So I'm so happy to also be with you and with you, Dr. Sherman. Thank you so much for being here today. Just to give all of our participants who have joined us today a little bit of background about you. You are a neurologist and movement disorders specialist, as Andrea talked about, in Tucson, and an associate professor of neurology and director of the Movement Disorder Center. You're an active provider as well as researcher. Your areas of research include deep brain stimulation, gene therapy, and cell-based therapy for Parkinson's disease. And you have articles and abstractions on understanding and treating Parkinson's. And we are so thrilled that you are here today, and you will talk today about apathy versus depression. And my name is Maureen Simmons, and I'm Vice President of Philanthropy, and I'm so happy and honored to introduce and to welcome you today, and to welcome all of our online guests.
Okay, so we got the right guy. That bio was
Yeah,
you?
that was me.
Okay,
I can't deny that.
Tell me when you're ready to,
okay,
I can
we're
start
ready
the slides.
To go.
Okay,
we're ready to go.
Pull up the slides here. Share screen.
Okay, or you can just put the camera on me for a moment if that's.
It's going to start.
Or are they going to see me and the screens?
They are going to see the PowerPoint.
Oh, let's go back just to me so I can talk to folks for just a second.
You're back.
Okay. Hello, everyone. Thanks for joining us today. So we are in the Biomedical Research Building, and I wanted to do it from here. This is where I've been for the summer doing research. The type of research that we mostly do is more on the cellular and molecular basis of Parkinson's, but we're looking at developing some new treatments for Parkinson's, also repurposing some medications that are already out there and trying to find how best to use them. When the Parkinson's Movement Disorder Alliance approached me a while ago, I wanted to pick a different topic. And this wasn't one that I necessarily have any expertise in, but I thought in keeping with this being an experimental place, I would try an experimental lecture. So you all, or all of us, are involved in this experiment, and I've just sort of spent the last week doing a little bit of research on this topic and putting together a slideshow. It's aimed both for doctors and practitioners of medicine, but also at patients. So it might be a little bit technical, but we'll see how that works. I've gotten interested in this general topic of what we call the non-movement parts of Parkinson's disease. So we know that Parkinson's disease, the main thing has been tremor and slowness and stiffness, and we have lots of treatments for those aspects of it. But the longer that I've been in the field, the more that I've come to recognize that there's another set of symptoms that we call the non-motor set of symptoms of Parkinson's. And it seems that as we develop new medications and deep brain stimulation, other modalities, that we're doing better in controlling the motor, but we have this gap with some of these non-motor symptoms. And so I've been very interested in sort of exploring these, at least in doing some research. And in doing that, I came up with this topic, apathy and depression. And we know that depression can coexist with Parkinson's disease. And there's been quite a bit of research about that. But I think that apathy is a different topic that we haven't really explored that much. And so I wanted to go through that today. So I did put together a little bit of a slideshow here. Just in the last day or two. So we'll switch over to that and we'll take a look at that. And I'll try not to use up all of the time on the slides. I think we have lots of time. So I want to start with the definition. So what is apathy? What does it mean? And when you look up the definition, this is what we come up with, sort of a lack of motivation, and then a couple other things that are part of the definition. So a reduced goal-oriented behavior. And maybe we can talk a little bit in the question and answer part about what that means. And then there's also reduced emotional expression. And I think in Parkinson's disease, we have to separate that out from a change in facial expression, because we know in Parkinson's disease that there can be a change in facial expression so that people may not be as animated, or it may be hard to read their facial expression, but that's not what we mean by this. We really mean instead that there's a reduced ability for people to have those emotions either expressed internally or externally. I'm going to go to the next slide here, and I don't know how to do that.
I think it should be that one. Okay. Hold, please.
Of course, even with the new technology, we still have the same old technology problems.
Okay. Now, I'm going to... Oh, there we go. Is
well,
that,
I think
go too far?
We went one too far.
Okay.
Okay, and then different entity is depression. And so the dictionary definition of depression is that it's a mood disorder that causes a persistent feeling of sadness and loss of interest. And so there we already have a little bit of confusion, because apathy also can mean loss of interest. So I wanted to delve in a little bit in looking at these two things. So here comes the scientific part of it. And a lot of clinicians, in order to do research, they sort of come up with these menus of diagnostic criteria. And if you see at the top, and I don't know if those pointers work on this, I don't know if we can do that. If you guys can see the cursor, I'll try to use that. But this DSM, I'm gonna clue you into some doctor secrets then, so you know how we work. And you know, you can look this up on the internet too. But the DSM is the Bible, if you will, for psychiatrists and psychologists. So this is the book that we all turn to for definitions, and that we all refer to. And it's been an advance in psychiatry because all these words can mean different things, and we need to make sure we're researching the same thing. So we have all these criteria, but it's interesting, they get a little overwhelming sometimes too. So this is the fourth iteration of the Diagnostic and Statistical Manual, and it's a huge phone book style thing if you ever saw it printed out. We don't really talk about depression technically anymore because that has been replaced with this entity, a major depressive disorder. And if we look at that, it says that there's a depressed mood or loss of interest or pleasure in daily activities for more than 2 weeks. So that's one criteria. And this loss of pleasure we call anhedonia. And that's, we've learned, is a very important aspect of depression. It's not so much just being sad, but rather when there's been a change, when people used to be interested in something, or they used to enjoy or take pleasure from something, and that changes, and those things that used to be fun or enjoyable no longer are. We call that anhedonia, and that's a major criteria for depression. So that's one thing that we have to have in order to sort of call clinical depression. The other thing is that it has to be severe enough to impair function. So people can be suffering from sadness or this loss of interest, but it's not considered a major depressive disorder unless it's impairing function in one of these realms, in social, occupational, educational. So we have to have that sort of criteria and severity. And then we get into this menu aspect of it where you can kind of pick and choose, which I sort of always find a little bit amusing for the scientific diagnostic criteria. But you get to pick 5 of these 9 things that are classic symptoms of depression. So being a depressed mood or irritable, that seems obvious. We talked about the decreased interest or pleasure. And then some other things that you don't have to have all of them, but they kind of count toward the diagnosis. And that gives us some clue as to what's involved in this disorder of depression. A change in sleep, a change in activity, fatigue or loss of energy. And then the important things about depression are really number 7, I think, and number 9. These feelings of inappropriate guilt or feeling of worthlessness, and of course thoughts of death or suicide or making a plan are really important features of a major depression that we want to know about. So depression certainly occurs in Parkinson's disease, and we know that it occurs not because people are feeling sorry for themselves because they have Parkinson's or they have symptoms, but rather the depression is a biological part of Parkinson's disease. And I've got a slide that I'll show in a little bit for that. So in trying to look about apathy, there are diagnostic criteria that experts, I have that in quote marks because I'm not sure what that means. I mean, the old joke is an expert was someone from out of town with slides, and I guess if you're not in Tucson, I would meet that criteria. But in any case, they came up with this international consensus group of things that would define apathy. And I think I might have some slides in there. It's almost hilarious in a certain way how complicated they made it, because not only is there sort of that menu aspect of choosing from this and that, but they're proposing this sort of 3-dimensional model of being able to come up with how we diagnose it. And so this is sort of A, B, and C, and D. And what they're saying is a reduction in goal-directed activities. That's sort of the major thing, and that the symptoms after the last 4 weeks, I don't know, sort of how did they come up with the number of weeks, and that it should have functional impairments, that's C, and then of course not explained by something else, that's sort of obvious. And you can kind of look down here and you can see how many experts were involved in all of this. That's sort of how complicated things can be when doctors and scientists get involved with this. So I was thinking about this and trying to think about it in a way that we can kind of distill this and sort of make a diagram. And I think that the best way to think about these two topics is that there's some overlap with these. So if we have depression here, we know that many folks with Parkinson's disease have depression, and we're talking a lot of folks may suffer from apathy, this loss of goal-directed behavior. And there is some overlap, but the important thing that I learned is that these are different symptoms, and that people can have apathy, which is sort of this not caring about things, different than sadness, and that these can sort of overlap, but they might be separate entities completely. And some of the things that are unique to depression are guilt and feelings of suicidality or self-harm. It's hard to talk about those things, but it's good that we really take that head on and talk about that, because these things are treatable, and it's good to be aware of them. It's a common disorder that there's still some stigma about discussing, so it's good to put these things right up there on the slide. So we know that these are things that have to do with depression, but they're not part of So I was able to find a couple things that really were a little bit different, so that we can start to tease apart these two disorders. And then to make things even more complicated, is there's a third thing that is very important in Parkinson's disease, which is fatigue. And the definition of fatigue is not straightforward either, and understanding what causes fatigue is even more perplexing. But I think all of you would know, if you've been living with Parkinson's, you're probably well aware of what fatigue is, and it doesn't really matter what the scientific definition is to you. And all of us know, sort of, we have a common understanding of fatigue, but it's hard to define. But yet, again, it's something different than depression and something different from apathy, because one could be interested in an activity, and one could not necessarily have sadness or hopelessness, but you still might be too fatigued to carry out that activity. So I think this is a third area where there's some important overlap. And I would say, I didn't put this in the theme, but sort of pain is involved somewhere in the scheme too, but I didn't want to make this even more complicated, because it's complicated enough. So it's hard to sort out, but I think that from a scientific standpoint, that it's worth studying this. And what's interesting is that we know that there are brain circuits that are involved in depression. And I kind of have this cool looking diagram. I mean, I think it's cool because that's what I like to do. I'm a neurologist, and I wouldn't be doing this if I didn't think that these diagrams were interesting. But, you know, we want to benefit people too. But this understanding neuroanatomically is very interesting. And I think we, in the scientific field, we just accept this now. But I recall it wasn't that too long ago that depression was sort of this murky thing that was somehow maybe blamed on patients or thought of some defect in willpower or something like that. But now we understand better that it's a real disorder. And moreover, we're starting to figure out all of these brain circuits that are involved with it. And the interesting thing that I don't have on this slide is that the overlap that this has with Parkinson's disease. And so I'm going to point right here to this area that's in the brainstem. Because you see that is sort of central to this depression. And that's also an area that probably many of you recognize as where dopamine cells are damaged in Parkinson's disease. So there's this anatomical overlap between depression and Parkinson's disease. Now, some of the motor symptoms like tremor, slowness, and stiffness probably involve this area of the motor cortex, but I'm sorry to keep doing that. But we see that these are called limbic circuits that are sort of on the lower portion of the frontal lobes. You know, the eyes would be here. This is the prefrontal cortex that's involved in depression. And these days, with the proper tools, on this side, I have shown a slide that is an experiment that is done commonly, which uses functional MRI. So we have sort of an MRI image, so we can take a subject, a patient, put them in an MRI scanner, and we can do something, show them a video clip or something that might make them happy or sad, and we can see what areas of the brain respond to that. And we can see that, for example, in depressed patients, there's sort of this overactivity of this prefrontal cortex that can be, or change in activity that can be important. So we're beginning to understand the biological substrate of depression. And that's important because eventually that, I think, will lead to better treatments. We know that apathy is somehow involved in these same circuits, but I wasn't able to find a slide that shows specifically what circuits are involved because I don't think our understanding is quite there yet. We know that it has something to do with this prefrontal cortex, but there must be a difference between apathy and depression, and I'm looking forward in the future, particularly in the context of Parkinson's disease, for researchers to really delve into this so that we can understand the difference of these. Now, getting back to this idea of depression and apathy being something different, here's a scientific study that looked at the percentage of patients that had one or the other or both. And they used sort of a questionnaire, not a brain scan, but just a questionnaire to sort this out. And they looked at two different disorders. So sort of as a control, they looked at patients that have dystonia, which can be one of the symptoms of Parkinson's, but they're talking about patients usually with a genetic disorder that has stiffness and increased muscle tone that in some ways is similar to Parkinson's in its symptoms, but a different disorder. And so this kind of controls for, you know, if people are just suffering from their physical manifestations versus something intrinsic to Parkinson's disease. And what we see is that in 30% of patients with Parkinson's disease, they had apathy only. In other words, they lost this motivation, but they weren't suffering from depression at all. Whereas in the dystonia patients, you know, they might have had depression and apathy and depression, but they didn't have apathy alone. So the point of this is that we can separate these out scientifically, and when we do, there's something about the type of damage to brain circuits that's occurring in Parkinson's disease that can specifically cause apathy. And so we should increase awareness about this on doctors and patients so we can perhaps start solving this problem. And then with some more research, I don't have a figure here, but just sort of the title of an article that was actually published, 8 years ago or so. But still, what these researchers found is that apathy is a major determinant of the quality of life in people with Parkinson's disease. So if you didn't study Parkinson's or you weren't part of the Parkinson's community, you might think that your quality of life would have to do with things like tremor or slowness. And of course, those do contribute to it. But as we tease this out, we're finding that the things that we need to pay attention to, because really we don't care about if we just take away someone's tremor, that's nice. But we really ultimately, as physicians, and if we're involved in this community, we want to increase the quality of life. So this is the most important thing. And so we found that apathy is. And there's a quote here that apathy is very common in those recently diagnosed with Parkinson's disease, and it's a major determinant of quality of life. And so this comment, it should be one of the primary concerns among clinicians who provide treatment to individuals affected by PD. And so I think that's a good statement, and I think all of us in the Parkinson's community were aware of it, but I think this kind of highlights that we should sort of have concern about it. It should be higher on our list of things when we see patients to think about. Well, having said that, like what do we do about treatment of apathy and or depression? And we have kind of the list of the usual things that we turn to. And we know that these work for the motor symptoms, and to some extent we know that these can help depression. But they may be more problematic with apathy. So the first one is counseling, maybe talk therapy, seeing a psychologist or a psychiatrist. Well, we know that in this climate of healthcare reimbursement and what have you, that it's hard for patients to see a psychologist or a psychiatrist. And so, but counseling might be important. But if people, the very nature of apathy, about not caring about something, may make it particularly difficult to seek counseling for this. And plus, we don't know if counseling works for apathy. In depression, we know that all these modalities, medication, exercise and physical therapy and counseling, sort of play equal roles in that, maybe a third each in kind of treating it. And with depression, we know that psychotherapy, if you will, or counseling alone can be effective, and medication alone can be effective, and the two together can even be more effective. But we don't even know if that's true about apathy. And physical therapy and exercise, boy, it's hard enough to do just to get motivated normally for anyone. If you're not used to a regular exercise program. Though, of course, we advocate that, but if someone is apathetic and they don't care about that, how are we going to really see to it that they take advantage of this? So with apathy, these modalities become particularly problematic. Medication, we need to know more about it, and deep brain stimulation is yet another topic that needs a little more study. And I was able to find one interesting article. Many of you are familiar with the benefits of deep brain stimulation. Of course, it can reduce medications, it can treat dyskinesia or abnormal movements, it can stop tremor. We're all familiar with these things, but we also know that there's a debate that DBS maybe worsens depression. Certainly the way that we do it traditionally for Parkinson's disease, using our favorite sites of the subthalamic nucleus or the GPI, if anything, we have to be concerned that we don't worsen depression, but we don't see an improvement in depression. We know that. So that's something that we're aware of. But what about apathy? Well, interestingly, there's a lot of data here, so I'm not going to go all through it, but I just wanted to maybe point to this kind of square here, which shows these bar graphs kind of show how much the improvement was in each thing with the DBS off and on. And so they're kind of pointing down because with anxiety and apathy, we want to make them better. So the less they are, the better. Uh-oh, I did something here that you're going to have to...
Okay, let's see.
Let's see what I did. Well, we'll live with this for a second, and maybe, I think what happened, they just opened this in a different window. So let me close this and see if we get back to... Okay.
See, you fixed it yourself.
Yeah, okay.
I'm going to go take a nap.
Okay, don't do that. Probably everyone out there might be asleep already. I can't see their faces. So, okay, so anyway, the point is that interestingly, DBS, when we turn it on, that it actually improves apathy and it improves anxiety. So that's not something that would have been obvious to me. but it's an important piece of information. Now, this is just one study, so we can't put too much weight on it. But I thought it was interesting to delve into this. And this was 4 years ago, and I haven't seen another paper about that since that. But we certainly should learn more about it. Maybe we can even use DBS some settings to improve apathy. And then medical treatment with apathy. A few things to keep in mind is that apathy may not respond to antidepressant medications. In fact, it may actually worsen with their standard type of what we call SSRI drugs that we use. And it may improve with the dopamine agonist drugs, which are things like ropinirole or pramipexole, Mirapex, Requip, various new agents that might be on the market, the dopamine agonists, might improve that. So that's worth knowing. Now, we use those anyway. But this is important information that antidepressants might help the depression, but not the apathy. And then some possible things that we should think about in treating apathy rather than depression. One would be stimulant drugs like methylphenidate, which is Ritalin, other types of stimulants. I think that those might actually improve apathy, but I was just able to find one article in the literature about Parkinson's disease, so that certainly needs more study. And there's other reasons to consider medications like Exelon or rivastigmine or donepezil, things in that class of medications that we use to improve memory and concentration may actually improve apathy as well. And that's judging on those brain circuits that I show, so we can make some predictions. But all of these really need study to see if any of the medications, what they have an effect on apathy directly. So enough with the lecturing here. So just to kind of summarize is that what I've learned and what I'm sharing with you is apathy is a common problem among people with Parkinson's disease, that apathy is different from depression, and that apathy requires a specific treatment that we need more research into studying to find that. So thank you for letting me share with you kind of this, my recent excursion into this, and let me put back the camera and see if anyone's still with us. If there's any questions, I'd be happy to take them if the technology works.
See. So I see some coming through on chat.
Okay.
And, oh, I have to unmute Maureen so she can ask the questions. I got it.
Okay, you got it from there. Great.
Yep.
Hey, thank you so much, Dr. Sherman. That was really, really interesting. And as Andrea mentioned, for anyone that has a question, if you would just raise your hand and we'll address your question. But this question comes from Facebook. And the question is, my mother seems to have mood swings and is sometimes apathetic. Give me just 1 second here. And sometimes depressed rather than all the time. Is this just my perception, or is there a medical explanation for this?
You know, and one sort of disclaimer that I should have made at the beginning of this that we should always make with these is that we don't want to give any specific advice to any one patient, you know, just over the internet without really formally seeing them. But I think your question has a general aspect to it. And I would say, you know, I do not know the answer to that question. We think of depression and apathy as not something that comes and goes, but something that would be persistent for a number of weeks. And that was built into that definition. So I guess there is it's a good question, and there's an important aspect to that. But having said that, I think that what people notice externally and what people feel certainly can have some ups and downs during the day. And so I think that's sort of needs some finesse, and I don't know that the definitions have really addressed that. I mean, if it's something that just happens at a specific time in relation to something else like medication cycles, or if you're hungry or asleep or something like that, I think it wouldn't meet the definition. But I think there certainly could be a waxing and waning of symptoms. So good question, and I appreciate that. We'll have to think about, what the ramifications of that is. It's interesting because we have people just fill out these forms. That's how we get our information, and it may be reflected in how they're feeling at that moment. And if we give the form again an hour later, they might feel different. I mean, we hope not, because the questions are usually over the last 2 or 3 weeks, have you mostly felt a certain way? So we try to get at the persistence of these symptoms.
Okay, great. And here's another question that came in. From what I often hear from our support groups is that many psychomental therapists don't really see them to understand PD and often cause greater issues.
Well, there's a number of levels there of interesting and important topics. I mean, number one, from my standpoint, is just a lack of accessibility to psychotherapy to begin with. But then even among that creates another problem, which is, I agree, people that specialize in neurogeriatric conditions, and specifically with Parkinson's disease, are needed even more. I mean, I agree that that people that are practicing psychotherapy in whatever form, and I don't mean like old style Freudian psychoanalysis, I'm just using that term, sort of counseling or talk therapy of some sort. They should be seeing other patients with Parkinson's disease in order to understand all of the ramifications of it, and they should be learning something about it. I don't think there needs to be a formal special qualification necessarily, but just like with your neurologist, I think patients are good to ask, how many people have you seen that have my problem? What's your level of expertise? And I think medical practitioners, should be honest about that. And if you do it all the time, that's one thing. If you're the third patient with it, if it's a rare thing, I'm honest about that too. But I think that's a fair question to ask any practitioner. How familiar are you with this? And of course, it would be good to have some sort of quasi-scientific studies or something in the literature from some experts in these techniques publish something about what they found to be successful so that others know. So all of that is really lacking.
Oh, great. Okay, good. Let's see. So here's a question about the effects of yoga or meditation on apathy. Has there been any research about studies if those two things help with apathy?
No, there haven't been. I didn't come across anything about that, but I really appreciate that question. I sort of have this side interest in yoga and Parkinson's disease because I have some colleagues. I'm personally not adept at that, but I have some colleagues that are very interested and some patients that are very interested in yoga. And I've not seen anything about that particular question of yoga and apathy. So I'm going to have Andrea make a little note. And the next time I give this talk, I will delve into that a little bit in more detail. That's really interesting. I'd love to know the answer to that, or find out if there's maybe someone out there has some specific thoughts about if they know about yoga, if there's some aspect of it that might be particularly suited. I'd love to hear from them. So I appreciate that that thought.
Okay, great. And then can you say a little bit more about whether there's a correlation between anxiety and Parkinson's disease?
People with Parkinson's disease that compared to sort of an age-matched control are more likely to have anxiety. So that can be part of the non-motor symptoms of Parkinson's disease. It's very common, and I didn't show a graph there, but in kind of reading through the literature, I would say that maybe about 40% or more of people with Parkinson's have anxiety to a degree that's medically significant. And anxiety itself can have specific treatments. So it may be part of depression, but it can exist separately from that. We do know that there's a set of medications that we call benzodiazepines. These are in the class of medicine like Valium or diazepam or lorazepam. These medications have a specific effect on anxiety, but they're not often prescribed because they have some downsides, and particularly there's been kind of a lot of pushback about physicians over-prescribing this class of medications. But they can have a very specific role in treating anxiety associated with Parkinson's disease. But I think there's a little bit of an uphill battle because there's this perception that these medications are, quote, bad, and that doctors overprescribe them. And of course, there's been more and more restrictions from the pharmacy level in using them. But we should keep in mind that there are specific medical treatments for anxiety as well as non-medical treatments. So, and again, I think anxiety is different from depression and different from apathy. And so we really need targeted therapies for all of these. It's a really good question, but I did want to point out that medications like clonazepam and lorazepam, they have a bad rap, if you will, but they are good anti-anxiety agents. And I think they could be used responsibly by physicians and patients.
Okay, great. Thank you. Here's another one. As a layperson, how can I search studies related to Parkinson's? Do you recommend Google as a place to go to search for information?
If you just search Google, I'm a little bit concerned about it being unfiltered and what you might come up with. There's certainly some good stuff there, but you can run into some stuff that is not really true, or maybe it may be nonsense. There are databases that are open to the public where things are curated, if you will, and certainly any of the websites associated with, for example, Michael J. Fox Foundation, or I don't know what resources the Alliance has, but I would filter through a trusted organization. The other thing that you can do is the National Institute of Health, NIH.gov. You can go to their website, and there's a lot of good information, and you can just search Parkinson's disease. For example, you'll come up with lots of legitimate studies that have been done. The information's a little bit technical, but I think that the regular layperson can get a lot out of that. So search the NIH.gov website is another resource that people can have.
Okay.
The NIH also, they also have a resource that they make free to the public, which is called PubMed, P-U-B-M-E-D, which is what I used. I mean, I think our institution has a subscription to it so that I can maybe download things maybe in a little more detail. But a lot of these scientific articles are available to the public through PubMed and through the NIH. And I think that the lay public may do well to just read through the titles and maybe bring questions if they don't understand it completely to their practitioner. Any study that is sponsored by the National Institute of Health has a mandate to make the results public. So this research is not hidden away. There's it's available to anyone. It might need some interpreting, but the information is out there, and there's really no reason why the public can't be more involved. And often some of those sites they may also have some lay information that's available. So I wouldn't just Google it. I'd go through a trusted site. And maybe one thing that we could do with the Alliance, now that you mention it, would be to maybe come up with a little more specific instructions or some links to some organizations that you can trust the information.
Okay, great. One of our attendees wrote, I've heard recently that Tylenol use can cause apathy. Have you found any connection between Tylenol use and apathy?
Now that's something that I can delve into. So I'll make a note and search that. That last week in reviewing and preparing for this, I didn't see anything come up that linked those. But that's a specific question. I could type that in and find out if anything's been published about that. Knowing how those medications work, I'd be surprised, but that doesn't mean anything because, a lot of times there's associations that are surprising. So I can put that on my to-do list.
Okay, great. So another attendee asked about any correlation between neck pain and apathy and depression, and I guess maybe other physical symptoms.
Well, depression can overlap with a host of physical symptoms, what we call somatic symptoms of depression. And they also can make pre-existing problems worse. So there can be an interplay where if there is an anatomical neck problem, the pain or discomfort could be worse in the setting of depression. And so we know that there is a link, and there's certainly sort of somatic symptoms of that. And the question of apathy and pain tolerance, we don't know the answer to. So that needs to be looked into. But certainly there is a link between pain perception and depression. Now, if you're asking, does neck pain specifically, would a slip disc or would a specific neck problem cause depression or apathy? I wouldn't think so. It's more that that depression, pain, and a sense of wellness are sort of overlapped in the psychological realm.
Okay, great. Thank you. And then another attendee asked if you had any updates on the ketamine trial you were involved in.
I can update where that's at. We are writing a detailed protocol sort of this week. I hope to have it done before the end of the month. And then I need to submit it to our institutional review board for them to okay the protocol. And I hope to have all that completed mid-October. And so I'm hoping that we can enroll our first patient in November or very shortly. And I've been sort of setting out all the legwork. We've found some partners to do the infusion, and sort of behind the scenes, we're gearing up to do that. And so I'm excited about that. That's sort of been my the main thing that I've been doing this summer is getting ready for that. And in the context of this, I will point out that we're looking at ketamine for its ability to suppress abnormal movements called dyskinesia. But we know that recently ketamine has been found to have very dramatic effects in reversing depression. And it may be unique, and it may have a role in quickly reversing depression faster than the traditional antidepressant agents. And so when we do our study, we're going to look at depression and Parkinson's disease sort of as a side issue. But I think that I'm very interested in studying that, and I don't know what role ketamine might have in apathy, but obviously part of my interest in looking in these non-motor symptoms has been to sort of delve into what the potential benefits of ketamine might be that we'll study. And so, we may look at one of these apathy scales as well.
Great. Okay, great. Let's see, we have another question about music therapy or other alternative therapies for apathy and depression. If there's been any studies or about your opinion on how alternative therapies can help with apathy and depression symptoms.
Yeah, I think I don't know about music therapy in particular. I didn't run across anything with apathy and music therapy. It sounds like a great idea to me, and it seems to me. Yeah, I'm not a musical therapist, but I do. I'm a personal believer in the power of music to heal, and so I think that more specifically, like music therapy, there's quite a bit about music therapy in Parkinson's disease, and I think it's established that it can have an important role. Again, finding practitioners of it could be a challenge, and of course, you know, funding it is another challenge. Insurance won't necessarily pay for it. But particularly with these non-movement symptoms, I think that the alternative therapies, and we've mentioned a couple, music therapy and yoga, I think they could really have an important role to play in that. And I think that we could even do brain scans and sort of try to understand how these non-traditional therapies actually impact brain circuitry. And I'm sure that they do. And I'm sure that they would in very interesting ways. So, you know, hopefully we can muster the funding and manpower to sort of delve into that and have some answers. But yes, I think it's a great idea.
Great, great. And we have time for one or maybe two questions. But in the meantime, so go ahead and type them. Let's see, just as a reminder for everyone, PMD Alliance holds this free online lunch with docs. And thank you, Dr. Sherman, very much for speaking today on apathy and depression. They take place every fourth Wednesday of the month from noon to 1 Pacific time. And we just encourage you to go on site, go to the pmdalliance.org site to find out what will be spoken about next month. And we'd love to have anyone join us. We do have one question about cannabis and the effect of using cannabis for apathy and depression.
It's a good question, and we know that cannabinoid receptors are highly concentrated in the parts of the brain that are involved in apathy and depression and Parkinson's disease. And I showed you that slide earlier that kind of showed those brain circuits. We know that those are rich in receptors for cannabinoids. But I don't have any specific answers to that from the scientific realm. I mean, it would just be anecdotal. I think there's a lot of potential there. You know, I think that we sort of understand that cannabinoid research, particularly with cannabis itself, has not been robustly funded. I mean, it would be safe to say that it might have been suppressed, and in terms of federal funding, it's hard to get that. So I think we're still struggling with that. But now in the era of medical marijuana, it's really an important question, and you know, it really should be answered because certainly from a pharmacological standpoint, we would think that there would be effects on cannabinoids and apathy in these circuits, but we don't know if it's helpful, harmful, indifferent, or more importantly, what the details of how it might be helpful. So another important area for research, not one that's likely to be funded by the federal entities in the near future, but we can certainly, you know, at the state level, there may be interest in funding studies of that nature.
Okay, great, thank you. And one of our attendees says, thank you so much for providing this very important information. It was really valuable, and we are so grateful to you for taking time today to present on this really important topic. So I think if that's it, we will conclude for today. And once again, thank you so much, Dr. Sherman.
Oh, you're more than welcome, and I thank all of you for participating. This is an interactive part of it, and so I feel like we're working together, not that I'm doing you a favor by that. So I appreciate the chance to work together, and that's part of the process. So it's been off to a good start, and hopefully we'll hear more about this topic, and we can move forward together on it. So thank all of you for participating.
Thank you. Thank you all, and have a good day.
Okay. Let's see if you just click end meeting down there.
Thank you. Thanks so much for your